I have extra charge. I am overcharged. Assalamu alaikum. I don't know, this session probably has no moderator, but it's okay. This is a satellite symposium sponsored by Astellas. I would like to present myself first. It's okay, don't worry about it. Ayman Hejazi, I'm a hematologist at King Abdulaziz Medical City, Riyadh. So my task for the next 30 minutes is to present the management of FLT3 positive AML. How do I advance the slides here? All right, so this is a disclaimer. All right, so if we look at the timeline of AML treatment over the years, 7+3 has been there for more than 50 years now. In the early 80s, AML M3 had the advantage of ATRA discovery and treatment. And then HiDAC consolidation came into play in the early 90s. In addition to arsenic trioxide. And then everybody had a donor and was transplanted. Gemtuzumab ozogamicin came just before 2000, and then it was withdrawn from the market around 2006, and then came back with a different dosing schedule, mainly to treat favorable prognosis AML. In the late, in the mid, 2015 or so, since then, other molecules have come into market for the treatment of AML. And now, probably now, it's maybe for the last 40 years, we are now thinking of changing how we treat AML, adding these new molecules in specific group of patients with acute myeloid leukemia. Of course, as you know, risk stratification is extremely important. That dictates how we treat these patients. And the well-known risk groups are the favorable, intermediate, and high-risk groups. As you are well aware, AML-M3 is a unique entity that has the best prognosis. And then comes the favorable, the rest of the group, which is the A21, and the core binding factor leukemia, and the biallelic mutated CABB alpha. The intermediate group is mostly NPM1 wild type, but FLT3 is negative or low allelic ratio, in addition to translocation 911. High-risk group, the list is quite long. And you can see in the corresponding curves here that the survival and the outcome of these patients is really dismal, especially those who are FLT3 ITD mutated and have high allelic ratio. So FLT3 and AML. FLT3 is a receptor tyrosine kinase that is from the family of known to be as split kinases, type number 3. As you can see here in the green shadow, the FLT3 is mostly expressed in the progenitor cells, and it has similarities with other kinases such as the stem cell receptor and PDGFR. These are all from the same group, and that's why FLT3 inhibitors may affect these other kinase receptors that more or less of the same family. As I said, it's mostly expressed and its function is mostly at the progenitor cell level, but also dendritic cells have FLT3, and that's why probably FLT3 inhibitors carries this problem of dendritic cell being not really normally functional, and that's why probably patients are more prone to infection and sepsis when we use a potent FLT3 inhibitor. The FLT3 receptor anatomy, extracellular domain that is usually the receptor for FLT3 ligand, transmembrane domain, and intracellular domains. The FLT3, the most important where the most mutations happen is in the FLT3 ITD, internal tandem duplication, and tyrosine kinase domain. As you can see here, around 30% of the mutations happen within the FLT3 ITD. That carries the worst prognosis. The prognosis of FLT3 TKD mutations is still debatable. So once the FLT3 ligand is attached to the FLT3, the molecule comes to near each other and phosphorylated and exerts its function downstream signals through the JAK-STAT pathway that leads to cell proliferation and increased survival. The presence of different mutations in AML, we have learned that in addition to determining how bad or well these patients are doing, the frequency is different between different mutations. The most common being FLT3 in 37% of patients, followed by nucleophosphamide gene mutation, about 30%, and DNMT3A and the rest of the group. We know that the FLT3 mutations carry poor prognosis, especially the FLT3 ITD mutations. The FLT3 TKD, as we see here, is not very well known. These are the prognostic curves of FLT3 positive, ITD positive, negative at different levels, years from remission or overall survival. Not only the being positive or negative, but the allelic ratio is extremely important. So as you can see here in these two curves, high allelic ratio FLT3 mutations carry poorer prognosis than low allelic ratio. Low allelic ratio actually is more or less lumped within FLT3 negative groups. As you can see clearly in these curves, FLT3 ITD, on the left-hand side, the black curve is for no FLT3 mutation. The gray curve for FLT3 TKD, the D835 mutation, and the red curve is for FLT3 ITD mutated. As you can see, this group is having the worst prognosis. The presence of FLT3 mutation usually is discovered upon diagnosis, but also keep in mind that this can happen upon relapse in certain patients, in a group of patients. These are two small studies. The first study proved that 10% of patients actually develop FLT3 mutation upon relapse, and they were negative upon diagnosis. So it's advised that you do FLT3 testing upon each time of relapse that you can target. The development of FLT3 inhibitors started fairly recently, let's say. The first known is sorafenib, then midostaurin, and these are called the first generation FLT3 inhibitors. Then we had quizartinib and gilteritinib as the second generation FLT3 inhibitors, and we'll talk about these in more details. The first one to be approved in the first-line setting and consolidation was the midostaurin, based on the RATIFY trial, which has randomized patients to induction with 7+3 in addition to midostaurin, or 7+3 plus placebo in induction, consolidation, and there was a maintenance arm of midostaurin too. Sorry. As you know, this trial has been published back in 2017, New England Journal of Medicine. The overall survival, if you look at the median overall survival, it's a bit deceiving. See, because the median overall survival for midostaurin arm is 74.7 months versus Thank you. Thank you very much. But I cannot. The median overall survival for midostaurin arm is 74.7 months versus 25.6 months. But the inflection of the curve happened around the 50%. And that's why it doesn't really give you a clear or the degree of benefit that you might expect from the addition of midostaurin. The hazard ratio or the four-year overall survival probably gives you a better sense about the benefit of midostaurin addition to 7+3. As you can see here, at 4 years, 51.4% in the midostaurin arm were alive compared to placebo, which is 44.2%, and that gives you a better summary on the benefit of midostaurin. Event-free survival, 8.2 months median versus 3 months. Quantum R is another trial that looked at quizartinib, another FLT3 inhibitor that is a second-generation FLT3 inhibitor. This looked at patients in the relapsed refractory setting, randomized to either quizartinib or salvage chemotherapy. As you can see, these are the outcome curves. Hazard ratio was 0.76 with overall survival quizartinib 6.2 months versus 4.7 months for salvage chemotherapy. Difference is modest, 27% versus 20% after 12 months. We'll talk about first generation, second generation FLT3 inhibitors, comparing midostaurin to gilteritinib. As you can see here, midostaurin has, the more red dots, the more off-target effect. And if the red dots are big within the target, that means these are potent. The main difference between these molecules is potency and off-target effects. So advantages of midostaurin, it's a type 1 inhibitor, effective against both ITD and TKD mutations, in combination with chemotherapy, as seen in the RATIFY trial, prolonged survival for newly diagnosed patients with AML. Disadvantages, as a single agent, actually midostaurin has no effect, 0. It's a weak, probably FLT3 inhibitor, but that has given it the advantage of being able to be added to chemotherapy in comparison to second generation FLT3 inhibitors, which are more potent but have definitely more side effects. And that's why the combination with chemotherapy was, maybe it will carry a big risk of side effects. It has incomplete inhibition of FLT3 in vivo. It's poorly tolerated. Patients discontinue maintenance due to GI. Gilteritinib advantages, potent and selective FLT3 inhibitor, inhibits both ITD and TKD, prolongs survival, as we will see in the ADMIN study. Easy to titrate. Disadvantages, myelosuppressive, very potent, as we have seen the first slide. FLT3 as a receptor is important in the progenitor cells that leads to more proliferation, and inhibiting that receptor leads to significant cytopenia if you have a potent inhibitor. And this is why gilteritinib is a myelosuppressive. Has also very long half-life. So we'll talk about gilteritinib in the ADMIN trial that was published back in 2019, New England Journal of Medicine. It's a phase 3 open label, multi-center randomized clinical trial. It has eligibility patients with relapsed or refractory AML with FLT3 mutation, either FLT3 ITD or TKD carrying the DA35. Also randomized to 2-to-1 fashion between gilteritinib alone, 120 milligram daily, about 250 patients versus about 124 patients that have been given a certain salvage chemotherapy. And salvage chemotherapy was classified either high intensity or low intensity. The high intensity regimens, MEC or FLAG-IDA. Low intensity regimens, low dose Ara-C. Low dose Ara-C or azacitidine. So it was the choice of the treating physician to choose between these regimens as salvage chemotherapy versus gilteritinib. This is the disposition of patients. 370 patients, 247 gilteritinib, 124 salvage. In the gilteritinib arm, 64 patients went for hematopoietic stem cell transplant, and 40 patients of those resumed gilteritinib. 24 did not. We'll talk about the survival, but definitely more patients who have resumed gilteritinib, as you can see here. 16 patients were alive after 2 years compared to 2 patients who did not choose to continue gilteritinib. Those who were not transplanted, only 8 patients were alive in 2 years. In the other arm, 8 patients were alive in 2 years, those who had transplant, and only 6 patients in those who did not. Oops, this TV died. I don't know what happened, but I have to look this way. So this is the baseline characteristics of patients, well balanced between the 2 arms. As you can see here, that previous therapy of AML included even FLT3 inhibitor in some patients, in about 13 or 12% of patients. FLT3 ITD and tyrosine kinase domain mutations happened in about 2% of patients in the gilteritinib arm, but none in the salvage chemotherapy arm. High-intensity chemotherapy and low-intensity chemotherapy between those who chose 60% versus 40%. The endpoints of the ADMIR study, there was 2 co-primary endpoints, mainly the overall survival and CR/CRh, which is defined as CR with incomplete hematological recovery. Secondary endpoints included event-free survival and CR rates. This is the overall survival, the primary endpoint. At 12 months, 37% of patients were alive who were in the gilteritinib arm versus 17% in the salvage chemotherapy. The median overall survival was 9.3 months in the gilteritinib arm versus 5.6 months in the chemotherapy arm. This is the updated survival data. As you can see, as we go on, the difference is still there, but we know these patients, the prognosis is not really the best, but probably those who had transplant and continued gilteritinib are the best group of patients that survived for more. This is the overall survival that was maintained after censoring for the time of transplantation. You can see that the difference is there, 8.3 months versus 5.3 months. This is a post-hoc analysis that was not planned to be done initially, but was done after publication of the trial, looking at patients who resumed gilteritinib versus those who did not resume gilteritinib after allogeneic stem cell transplant. Again, showing a difference, 16.2 months of median overall survival versus 8.4 months. The secondary endpoints, this is the second co-primary endpoint, which is CR/CRh. You can see that definitely patients who had galtretinib had better or more CR/CRh compared to salvage chemotherapy. Patients benefited across all subgroups, as you can see here. This is very important, and this is what people are concerned about mostly sometimes, is the toxicity profile. The most common toxicity profile, in addition to hematological toxicity, is having high liver enzymes. You can see here, this is all grades. ALT, galtretinib arm, about 42% of patients had high ALT, and similar number of patients have high AST, in addition to alkaline phosphatase increased compared to the chemotherapy. The other toxicities were more or less not very much different. But looking more specifically into more grade 3 toxicities were mostly hematological, febrile neutropenia, anemia, and thrombocytopenia, and this was not really statistically significantly different between the two arms, chemotherapy versus galtretinib. The high liver enzymes, grade 3, was happening in about 13 to 14% of patients who have received galtretinib in comparison to chemotherapy. So what side effects we have to be concerned of in galtretinib is LFT abnormalities, as we said, are the most common. Those with high tumor burden, watch for differentiation syndrome that can happen, and this is a class effect because FLT3 is a receptor that leads to proliferation, and anti-FLT3 inhibitors can increase differentiation of cells. Skin manifestations are common. Rarely, you have to bear in mind that, although rarely breast syndrome can happen, and you have to make sure of the drugs that you use in these patients, as sometimes it prolongs the QTc interval. These are the NCCN guidelines based on the Admiral study and treatment of relapsed refractory AML patients, adults. They put galtretinib as category 1 in their suggestion compared to chemotherapy. So in conclusion, the outcome for FLT3 mutated AML patients are improving using FLT3 inhibitors. We have seen in the ratified trial the addition of midostaurin upfront improved survival in addition to chemotherapy. In the relapsed refractory setting, galtretinib, which is a second-generation FLT3 inhibitor, is active and has improved overall survival and with manageable side effects. With this slide, I conclude my talk. Thank you very much.